All right, well, good evening, everyone. It gives me great pleasure to introduce a dear friend and colleague in the world of philanthropy, Mitch Balk, who's been a stalwart philanthropist representing the Mount Sinai Foundation, a foundation that many in the field have followed and turned to for direction, especially as it relates to health and health type giving. I shared with him a little bit about what we're trying to accomplish and told him to, tell us a little bit about the work of his foundation, but also to talk a little bit about how the decision was made about the structure and the way they sort of operate. So he'll get into some of that. And I told him to also share any other words of wisdom that a group like this might need to know. So he's just wants to share some thoughts with us and certainly open to hearing your feedback, your questions in particular. So without further ado, Mitch Balk.
Thank you, Randy. I don't know how you got Randy to take on this gig. I mean, he's got a few other gigs, in his life. So, but good for you. He's a great strategic thinker, and great to see so many friends and coworkers in this room. I had no idea. I mean, Dan Cohn and I worked together, but all of you others, it's great to see all of you, and I don't know why you have my wisdom that you need, because you've got a lot of wisdom, I know, for a fact, around this table. So I share your excitement about this great adventure that you are on. I was privileged to open up the Mount Sinai Foundation 21 years ago. It's great to be able to give away money and have that satisfaction, but it's even a greater honor, a greater privilege to give shape to this emergent entity of yours. Again, I have some remarks, like Randy said, but I really want to hear from you as to where your questions and concerns lie, where the shoe pinches even. And so I hope there's lots of interplay here. And I'll tell you a few things about the foundation, but I want to get you really revved up to ask questions about your administrative structure and your tax structure and your grant-making aspirations. And that's where I think we should spend a lot of our time tonight. So the Mount Sinai Foundation was founded 21 years ago, but its history, as you know, stretches way back to the end of the 19th century, when the Jewish community of Cleveland began raising money to establish a Jewish-sponsored hospital. That institution, Mount Sinai, opened in 1903 and was generously supported by generations of Clevelanders. So fast forward 90 years, in April of 1996, the operating assets of the Mount Sinai Healthcare Foundation, which was 3 hospitals and lots of outpatient centers, et cetera, was sold to a for-profit hospital company. And so the legacy of Mount Sinai's philanthropy was passed in April of '96 to this foundation. We exist to perpetuate all that Mount Sinai represented to the Cleveland community, and I'll be talking about that when we get to our grant-making agenda. So you've probably heard the phrase, if you've seen one healthcare conversion foundation, you've seen one healthcare conversion foundation. We are all so different. We have come from similar transactions, but we are very different in terms of our grant making and our missions. And for example, many of us are focused on health and medicine, and some of us are focused on health and medicine not at all. So as an example. What makes the Mount Sinai Foundation a little bit different, and we won't spend a lot of time on this because I understand perhaps this is the burden of the other foundation that is emerging, is that we took the endowment from the hospital, and that was a big part of our corpus today. We were $150 million. And we have the endowment, which is subdivided into 400 different donor funds. So it sounds almost like the Cleveland Foundation or something. In fact, we talked about being a community foundation because we had donors who were kind of aligned and kind of hooked onto us, perhaps going forward. So we have the Smith Cardiology Research Fund, and we have the Jones Family Cancer Research Fund, and we use these funds as close to the donative intent as we can, given the Mount Sinai sale and given that those funds were given to help operate a tertiary care teaching hospital. That's not all our money. We do have plenty of money that's free and clear, but it does make us a bit unique in our world. So we give away about $7.3 million today. Obviously, we have a 12-quarter rolling average of assets we look at to smooth out any bumps in the stock market, but that comes to $7.3 million as a grant-making budget in 2017. What you really need to know about the Mount Sinai Foundation, and now we'll get into a little bit of our grant-making agenda, is that our very name is a misnomer. We are not about health care. The Mount Sinai Healthcare Foundation is not about health care. It's about health before care. We are ounce of prevention people, obviously, because this is where our philanthropy can do the most good. You know, in healthcare, let's face it, you know, philanthropy does not do the heavy lifting, and you know, we're not even a rounding error, frankly, on that operation. So if we're giving a lot of money to hospitals, you know, you got to ask yourself what's your impact, because especially with the disappearance of community hospitals like Mount Sinai and Lakewood and others, you know, the mega hospitals can kind of do whatever they need to do, almost anything, without philanthropy. And that's not true of a lot of other nonprofits, obviously, who rely very heavily on charitable giving. So I'll recover from that somehow. I will, you know, you won't quote me. So our 4 areas of grant-making focus currently, we didn't start out with these. We started out a bit different. I can talk about that if you'd like. But our 4 current areas very much reflect what the Mount Sinai Medical Center was in this community. So our first area of giving is the health of the Jewish community, as you would imagine. And we are very much aligned with the Jewish Federation of Cleveland. And when we came into being, we said to ourselves, look, there is another entity that is charged with the well-being of the Jews of Cleveland. They've been around for 100 years. There's no need for a second planning table in the Cleveland Jewish community. So this is all to say we let them take the lead in terms of identifying needs, and we're happy to be kind of the fuel when it comes to the Jewish community, and only the Jewish community. Otherwise, we think we're pretty strategic, and we are in the opportunities business, and you know, we move in that direction, so I'll talk about that in a minute. Secondly, and our biggest area of focus always is the health of the urban community, where we think the need is greatest, and of course Mount Sinai was a safety net hospital for the urban poor, and you should know that using the amount of adult Medicaid business as a measure, Mount Sinai was the largest private provider of care to the poor in the state of Ohio. You hear all these discussions about Metro Health and UH and the war about level 1 trauma centers and how many do we need. Well, Mount Sinai was always a level 1 trauma center on the east side of Cleveland. And so, you know, until Mount Sinai closed, there was always a trauma center there. Mount Sinai had the first and for a while the only emergency medicine residency training program. So, you know, there was always emergency medicine going on at Mount Sinai on the east side, you should just know. And the third area of grant making is academic medicine and bioscience, because Mount Sinai was a teaching and research medical center, and because, as you have heard from me, most of our funds that are designated for some purpose are designated for teaching and research medicine. So it seems to me we will always be involved in that field, and very few conversion foundations are involved in medical research. You know, that's an NIH thing. You know, again, the dollars from Mount Sinai are very small, and yet we really focus on building the capacity of Cleveland institutions to do research. We don't pick the horses. We don't say this year we're going to do Alzheimer's and next year we're going to do drug development and XYZ disease. We simply say we're going to build the capacity of Cleveland institutions, because we feel that this sector of the economy and this sector of what Cleveland is really important to Cleveland's growth. So, and we have these funds. And finally, our fourth area of grant making is government, is health policy. Why? Because, I mean, you all read the newspapers, especially this week, right? The biggest player in Cleveland healthcare was not Lakewood Hospital, it's not the Cleveland Clinic, not Medical Mutual. It is government, and what government does or does not do has an enormous effect on the populations that we in health philanthropy care a lot about, right? Children and seniors and the poor. So we work alongside government in myriad ways to, and some of you do too, and some of you are government, to strengthen government, to help government meet its obligations, also to advocate, even though we call this our health policy portfolio. And a lot of what we do is to educate policymakers. We also advocate. So when Governor Kasich, ignoring the political winds, called for the expansion of Medicaid in Ohio, we did two things. We could not remain silent. The first was we sponsored a study together with our friends at the George Gund Foundation and Interact for Health in Cincinnati that documented all of the beneficial effects of expanding Medicaid, both the economic effects and the human impact of doing so. Then we organized a faith-based response or support group, Greater Cleveland Congregations, but other places around the state, to add that faith voice to this fight. And as you remember, it was a fight in the legislature in his own party. So just health policy work, really, really important. Uh-oh. Phyllis? This is Phyllis? Okay, Phyllis.
She's sit right next to me.
Okay, we're going to give you the tutorial. No, can you hear us? I assume you can. Okay. Great. Talked about government, and now I'm just going to. So it sounds like by your name that you've chosen, or I don't know if it's a permanent name, the wellness. No, you haven't chosen this. All right. If you choose a name like wellness, you'll be in good company among health foundations if that indeed is where you're headed, because we all want to be upstream, because in terms of impact, this is where we think we can have the greatest impact on lives. One thing we really will have in common with you. Oh shoot! I think she's gone again. I see. Oh shoot! And this is a different zone. One thing that will be something that we have in common is that Mount Sinai very much considers our money to be community owned. We are not a private foundation. We are a public charity in terms of our tax status. I can go through that with you, but we still get donations, not major donations. We're not campaigning out there. We don't have people on the street like the Cleveland Foundation. But we are a public charity. We've only ever been a public charity. And in terms of our job as a philanthropy, our job is to listen to the community, right? We're not so arrogant as to believe that we know where all the needs are, even though we sit in an ivory tower at Case Western Reserve University. Really is, not a good statement to make. But we truly want to listen to the community. We want to align our grant making with documented community need. And to do this, we must be research-based and data-driven. We are both in the needs business. That's where the data comes in. But we're also in the opportunities business. And opportunity means you got to assess what you got, and you got to be strategic about where you're going, right? And I think everybody here knows that to be strategic means that you start with the ends in mind, and then you devise a roadmap on how to get there. So in grant making, I know a guy named Paul Brest from the formerly of the Hewlett Foundation. He was also dean of the Stanford University Law School. Used to say strategic grant making versus regular grant making. It's like the difference between putting your destination in the GPS and taking a Sunday drive. So pretty dramatic, difference in terms of what you need to do to really be impactful in designing strategy. So that's kind of what I wanted to open up with, and I really love to hear your questions, your concerns about, again, this great adventure that you're setting upon. Yes?
Hi, thank you so much for being here this evening. How did your group determine 21 years ago that the public charity was the right structure?
Okay.
Can you talk a little bit about
Sure.
the decision-making behind that
Absolutely.
structure choice?
Part of it was historical. We had never been anything but a public charity, because when the hospital kind of became on the block, or in play or whatever, we knew it was not going to be a standalone hospital. We knew we had this fairly substantial endowment, and we wanted to separate it from the operating stream of the medical center. So we created the Mount Sinai Health Care Foundation. It was a supporting foundation of the hospital, so it was already, in terms of its legal and tax status, a 501c3 public charity, and it was a type 1 public charity. So when we were about to lose our tax status, because after you can't meet the public support test after a while, you automatically will become a private foundation and have to pay the excise tax and do all these things. You probably have lots of legal minds in here. I'm not one of those. We decided we needed to keep our public charity status because we still had donors. We still had donations. And there are some limitations when you're a private foundation to self-dealing. There's some other private foundation detriments. So what we did was, and each conversion foundation has a similar story in town, we went to the Jewish Federation and we said, we've always been a supporting foundation. You've got 49 other supporting foundations. They're almost all family foundations. We want to be a supporting foundation to keep our public charity status, but we can't have you appoint all our board members because that's just, our board is out and about and, we're already a self-perpetuating board, et cetera. So we got an IRS private letter ruling that basically said the Jewish Federation and the Mount Sinai Foundation each have veto power over the other in terms of who comes on our board. That's just what we did. Obviously, we hired counsel to get that done for us, and it's worked fine. But that's why we're a public charity. We're officially a supporting foundation of the Federation. They do not have any management involvement in our foundation. We do co-invest with them now. There are a couple of pieces of money that we put in together and oversee jointly, but we have separate investment operations. But that's in addition to this appointment process to the board, which is kind of unusual. The only other overlap is we do co-invest maybe $20 million, $30 million.
And what's your total endowment right now?
150 million.
Thank you.
Actually, I have a few questions. Do you mind?
Absolutely.
With regard to the endowment, was it a one-time endowment, or is it a recurring endowment?
Well, okay. The day we left the hospital, we were about $66 million. We took the endowment, all the philanthropic funds at that time. The 1990s stock market was good to everybody. We grew to maybe 90 million. Then we had a parallel closed-down operation of the medical center. The do-tos and do-froms from Medicare and Medicaid, all that kind of closed down. We also had a lot of assets on the books that needed to be liquidated. We owned 30% of the Glidden House, and we owned 30% of the Centers for Dialysis Care. Is that what the Diane Wish? We had an investment there. All those kinds of things at Mount Sinai that hospitals invest in and have money had to be liquidated. So make a long story short, the board of the old Mount Sinai Medical Center, which only existed to close down the affairs of the hospital, which, believe it or not, 21 years later still exists, and now I'm the executive director of that. And anyway, they, with a lot of legal work, got us the proceeds of the sale over many, many years. We had indemnification. We had certain reasons we had to leave money on their side of the ledger. The company that bought Mount Sinai went bankrupt, and there were all kinds of lawsuits, and so they then sued us, and it was a mess for a long time. And that's kind of the Mount Sinai flow into the St. Luke story is a lot cleaner. They had an overfunded pension fund. You probably heard from them, I don't know. But so their money flowed in easier.
Mount Sinai Foundation's been around for a while. Do
Yeah.
you guys project growth as a public charity? And how does that, and where do you foresee that growth?
Well, we would really love to be involved. The optimal thing to do here is to do good in the community while you're growing the fund, right? But the problem with growing the fund, you got to do it in terms of maintaining your grant-making impact, obviously, in terms of inflation. But the problem with growing the fund is that you no longer have donor opportunities to recognize donors for those very large funds that would really make a difference. In other words, if you were wildly successful and you were able to raise $5 million, over a couple of years, given the fact you don't have buildings to put people's names on, and things like that. Okay, so what would you be, you're only giving away 5%. So it wouldn't make a huge impact on our grant-making agenda. Now, as you know, the Cleveland Foundation, in particular, does a great deal in terms of fundraising, estate planning kind of work. And we've always talked about being in that business. We haven't yet had consensus.
I see.
But you'd have to be really, if you're starting out with a sizable endowment, you'd really have to bring in those tens of millions to really, up your grant making. 10 million would be 500,000, right? So it's not chump change, but it's not going to change the world. You'd have to be wildly successful.
And my last question is, you identified 4 focus areas for grant making. How did you come up with those 4 areas?
Yeah.
And are those enumerated in your bylaws, or do you have the flexibility built in to determine and kind of change where that focus is?
We totally have the flexibility to do whatever we want with our money. The money is at the discretion of the Board of Trustees for use in its grant-making program to in furtherance of its charitable mission. Now, we started out with a couple of other areas. We came about when all the brain science was coming on board about, it's important to stimulate your baby's brain before age 3 because, certain windows close and the neurons don't get connected. And, so we took this on for a while. We did good work, but, it was too focused for us. We still have a huge focus on early childhood because of our early intervention, primary prevention approach. But we don't do early childhood in the same way we did. We had a focus on seniors because, demographics, and we have some wonderful legacy projects. I haven't given you any examples of our strategic grant making, but I'm happy to. But we no longer have a grant making category called aging. And then the real one that we dropped was we had a category called organizations, and that focused on capacity building of all kinds of nonprofits. And what happened there was we started getting numerous requests for software and hardware upgrades at a time when everybody had to start billing the state with electronic billing systems. This was before electronic medical records. This was 15, 20 years ago. And a lay board got no satisfaction out of giving money for computers in big dollars. And then there was the tragedy of, we gave $120,000 to an organization, and the darn thing was never implemented. You've heard these nightmare stories about software that just doesn't do it. So we've learned a lot of lessons, and we're not permanently, fixed in one direction.
Okay, thank you very much.
Of course.
Can you tell us a little bit about the composition of your board and
Sure.
the composition of your staff?
Yeah. Well, this is an embarrassment, but I'll tell you because I have a lot of friends in the room, and they'd tell you when I left. I'm sure. First of all, we have an all-Jewish board, 27 people. When I moved here from Chicago, the hospital was an all-Jewish board. I'd never heard of that. I mean, in Chicago, the Jewish hospitals didn't have that, and frankly, it was bad for business. Like there's not enough Jewish people to use the hospital. You gotta spread out. It's just bad for the hospital business. So that's number one. 27 folks. They're great. I mean, we engage them in site visits. We encourage them to attend our site visits, and they have a lot of influence in terms of, but at the same time, they add a lot to the grant seekers thinking, because they're experienced in business or nonprofits. And so I think it's been an enriching experience for everybody. But the people who come on our board say, we love the Mount Sinai board and we love the site visits. We learn so much about our Cleveland. And they always tell me it's their best community assignment ever. They're really satisfied. In terms of the staff, we've had a staff of up to 7. Right now we have 6. We have the program staff and we have the administrative staff. So I'm part of the program staff, and then we currently have 2 program officers. One is Dan Cohn, who is in charge of a lot of our strategy, but is also the urban health program officer. He's got a rich background that he probably told you about over the time you've known him. And we have just hired Carol Bialostowski, who used to work at the Cleveland Department of Public Health, who has an MPH from Columbia and who did a lot of work on the Hill, so she's got a bit of a policy background before she moved to Cleveland, and she's only been with us since January. She happens to be married to Steve Dettelbach, who's running for Attorney General. So we also had, once upon a time, a program officer just for policy, and she did a great job. She was very focused on the implementation of the Affordable Care Act in Ohio. So everything related to enrolling folks who maybe didn't know they qualified for public sector programs. You heard our focus on government, and we did really great work in those months. And she was with us maybe 2 years, and I decided not to replace her when she left because, and I was right, things quieted down relative to the implementation. And then we have an administrative staff that consists of my main person, Lisa, who some of you know, who's she's the glue. We have a wonderful woman, Janice, who runs our grants program. She's the grants assistant. She's in charge of every grant that we give and the software program that manages the grant making program. So she's kind of the grants manager. I guess I don't think that's her. I think her title is grants assistant. We have great longevity. I mean, these folks seem to enjoy coming to work and get satisfaction, and not a lot of turnover. And then we have a terrific part-time finance person who was one of our auditors from Ernst & Young way back in the hospital days, left to start a family. When she was looking to come back to work, we said, how about coming back part-time? So she's been with us for almost, I'd say 18 years. And for a while, for several years, I got a call from Denise Seaman, said, we love Melanie. We're looking for a finance person ourselves. Do you think we could share Melanie, I said, absolutely. She's great. So that happened. That lasted several years. But, we're very collaborative with our brother and sister grant makers. Yeah,
Mitch, do you have target percentages for allocations
Excellent
across your 4 focus
Such a
areas?
great question.
And secondly, do you consider your strategic grant making to be the same as proactive grant making?
Yes.
Can you tell us more about that?
Yeah, I do. I think those terms are pretty interchangeable, although I emphasize the strategic and what that meant to me. We don't do 25% of each of the 4 categories. We do 100% of each of the 4 categories. Not 50% of each, 100% of both. We've never had an occasion, and I imagine that at Gund or someplace like that has arts and human services and environment, they're so separate from each other, they have to do just that. And some of you guys have a lot of experience with the Sisters of Charity or somebody else. But we don't do that. We simply say, and if I have to, I'll say to the board, we're going to go over this year. We're going to spend a lot more money in policy this year because of what's happening in Washington. And it's not going to be repeated, but this year we need to spend these dollars here. So the board's been very, very good about understanding that. So no, we do not have. And your other question was?
It's just telling us more about the proactive strategy.
Okay. So as I said, we see ourselves as being in the opportunities business. So I'll give you just a brief example. You'll tell me if it's too much detail. So years ago, Shelley Galvin, program officer, and I were talking about our in-laws and how people are doing in their senior years, and how my mother-in-law at the time could take a bus and go to a synchronized swimming class, even though her walking was really terrible. And I don't know, she managed to get out of the house this way. And that her mother in Florida, I think, could take a bus and go to her volunteer job at the library every day, and the bus would get her home safe and sound. And we looked at each other and we said, you know, with our demographics in Cleveland, with our aging demographics, with our climate, you know, we don't want seniors waiting on the street corner for a bus. You know, maybe we should figure out if there's a way to do this citywide, you know. So we went to Jane Fumick, who ran the county health department at that time. Then she ran the city Department of Aging. She's wonderful. And we said, what would it take to create a system of senior transportation countywide that was safe and affordable and dependable, door through door for frail seniors too, and God willing, sustainable into the future? And what resulted from that conversation was she went to the county planning department, Paul Alcinas, and they submitted a grant to the Mount Sinai Foundation to write a business plan, to first do reconnaissance study worldwide, senior transportation. We heard from Stockholm, Sweden, but then a lot of places in North America. And they wrote a business plan about getting senior transportation off the ground in Cleveland. We had a lot of partners. We had philanthropic partners. We had United Way at the table. I mean, this was not just a Mount Sinai thing. And make a long story short, you know, Senior Transportation Connection of Cuyahoga County is celebrating its 12th anniversary. I've been on the board the whole time. You know, we've put a lot of money in, so have others. But right now, 80% of its revenue is coming from earned income. Their clients are all the municipalities, not all, but lots and lots of municipalities in Cuyahoga County. RTA has been a terrific supporter and has given much advice and business. They've thrown business to us. So that's a wonderful example of how we're in the opportunities business, or we know there's a need and we pursue ways to meet that need. And sometimes they're at scale like that, and sometimes they're much smaller.
Couple things. Can you give me some insight in terms of, you know, what your overall expenses from a percentage standpoint look
Yes.
like each year?
Yeah.
Also, given where you started in terms of staff and how that's grown over the years.
Yes, absolutely. Okay, so the first question is we're about $1 million of spend every year. Now, we have we cheat a little bit because like we live in the Allen Medical Library on the campus of Case Western Reserve University. I wanted this foundation to be in the center of the medical community. We do not pay Class A rent. Like, you know, they don't charge us what they probably should. On the other hand, who's been to our office, you know, we're like, you know, we're along a hallway, you know. I mean, it's kind of like not the way that people recommend to set up offices today. So our rent is low. We have other low expenses, like if I need computers, it's cheaper and easier to just order them through the university, and they let me do it because we have a billable account thing through them. So $1 million, I would say, you know, probably 600,000 is personnel. And you know there are safe harbor rules about how much you should spend as a foundation. So it's between 0.5 and 1.5% of your corpus is what you should be spending on expenses, and that's according to the Council on Foundations, even though that organization serves private foundations, not public charities, by the way, except for community foundations, which they do serve. That's a good guideline for you to probably think about. And your second question,
How did you grow the staff over the course
Okay.
of time? And I guess also, how did you determine the size of the board?
Okay. So the staff grew this way. We had segmented out the philanthropy at the hospital. So we created the fundraising arm of the hospital, which really also was going to morph into the grant-making foundation after the sale. And Shelley Galvin and I were kind of the staff of that foundation, along with another woman, Marge, who kind of managed donor relations. And the three of us and our administrative assistant became the staff of the foundation when we left the hospital. So we were 4 people. Shelley and I did the programming stuff. And I told a joke at our annual meeting when Shelley retired that it took 2 of us in those early days, 2 yes votes for a proposal to go to the board. Like if I thought something was great and Shelley said no, it was no. We had to have 2 votes, I don't know, I thought this was funny at the time. So getting that second vote out of Shelley was like hell on earth, you know, she was tough. But that's how we started. That's how we operated in those early days, kind of a secret, you know, Mount Sinai story. The board started out with 21. And we thought 21 was a good number. You know, hospital boards are very large for fundraising purposes, right? So these hospitals could pick 60, 80 people, some of them. We wanted to limit our board size to something that looked like a foundation, so we picked 21. But the problem was our board folks were so senior. It was hard to get the voice of younger people. It was hard to get diversity on the board. And so we expanded to 27, and that was perhaps only 7 or 8 years ago. It's tough to get young people engaged. They're busy raising a family. They're busy building a career. So what we end up getting on the board are really outstanding community servants who perhaps are retired, who no longer work, and you know, for whatever reason. And they're great, but we do miss the voice of that average citizen, you know. Martha.
Mitch, you had mentioned that you are focused on doing upstream work.
Yes.
Have you done anything intentional within the foundation to weave equity, like, you know, have you done
Yeah.
capacity building with staff, or are you weaving it into your grant making in any way?
We are like so far behind in this work. Dan Cohn, to his credit, has brought us along, and we have had, Dan and I have attended some equity trainings in DC. I mean, part of our portfolio, you know, obviously in urban health is reducing health disparities in minority, you know, communities, but that's not the same as having a real equity lens. So we have started the conversation, and I was really either smart or really weak. I started with women on the board. They totally got it. They were with it 100%. And then I invited a couple of guys who I thought were going to have maybe some questions about this approach. And they were pretty good, too. I don't know if they were just being polite or if they didn't get it, but they seemed to nod and say, yeah, that sounds right. So we've got to get back to it, but Dan can tell you all about what our experiences has been. We are nowhere near where we should be. As I said, we got to start with the fact that, you know, we serve the urban community, which is the African-American community in Cleveland to a large extent, and we have an all-Jewish board. Now, that's wrong. So, you know, I don't know if we're going to get there soon. We have a better, more diverse staff, but, you know, probably not enough. The board terms are 3 3-year terms, so a total of 9 years. Yeah, and we've brought a few people back. Yeah, we've brought a few people back. Now that we're 21 years old, we've had people rotate off the board and bring some back. We try to bring some physicians on the board. Obviously, finance folks, I don't know what you're going to do about your investing, but we have a independent investment operation that's done really well. We've got Bob Grease, who's been on the Mount Sinai Investment Committee since 1960. Can you imagine? So he's rotated off the board now, but he remains on the investment committee. We have a few committees like that where we have outside members, but mostly it's the investment committee, people who have served on the board who are now just on the investment committee, and we are grateful. Yeah. You know, we've talked about setting up advisory committees, but at this point we do not. We invite certain guests to board meetings or to committee meetings. We get expert advice when we need it, either volunteered or sometimes we pay for it. But at this point, we do not have advisory committees. And speaking like I did, saying we really view ourselves as being community-owned, you know, that maybe is not reflected in the fact that we don't have those committees. Okay. So the investment committee, we have a finance committee. The finance committee basically meets 2 times a year. The first time to review the audit, and the second time to approve the budget and recommend the budget to the board. We have the Grants Committee, the all-powerful Grants Committee with its 2 Grants Committee co-chairs. We select folks who could make site visits, but we then invite the entire board to those Grants Committee meetings because this is where we roll up our sleeves and we make a decision, basically. We double-click on the proposal. And then at the board meeting itself, you know, we have a really perfunctory process. We do read grants over $50,000, but, you know, people who didn't attend the site visit or the Grants Committee are woe to comment at the board meeting if something has progressed to a recommendation from the Grants Committee. So we encourage people to attend the Grants Committee. We invite everybody, but not everybody has a vote. That's the Grants Committee. But what we really have programmatically under the Grants Committee are our strategic grant-making advisory committees. Now, there are advisory committees, but there really are not outside members. They're all board people. The strategic grant-making advisory committees are Health of the Jewish Community, Health of the Urban Community, Academic Medicine and Bioscience, and Health Policy are 4 areas of grant-making. And that's where we can, again, do a deep dive into where we're investing our money. We can do cluster evaluation of a group of grants. We can really assess, you know, the direction and make mid-course corrections to our strategies. So that's where a lot of the real action is on the strategic side, on the bigger grants that we make. We have a Saltzman Award, which is kind of a Lifetime Achievement in Medicine Award. So we have a Saltzman Award Selection Committee that meets. We used to have a grant evaluation committee, but now we do all that evaluation work through our advisory committees, those 4 programmatic advisory committee meetings. So I might be missing something. Investment committee, I talked about a little bit. Mm-hmm. Yes.
But how are they guiding some of the decision-making of the board and encouraging, of course, encouraging decisions that you make?
Right. Well, it's different in every category of giving. So in the Jewish community, when we started up, we hired Lewis Harris and Associates, you know, the Harris Polls people, and we did an assessment of health and well-being in the Cleveland Jewish community. And we found out that, you know, 14% of Cleveland adult Jewish people smoke. We were really surprised at that high number, and so we, you know, launched some smoking cessation programs. We found out that, you know, very few folks knew about long-term care insurance, which is such a win-win for institutions and the consumer. So we launched educational sessions on long-term care insurance. In the general community, we rely on existing infrastructure like the Prevention Research Center at Case Western, city and county data, state data, and you know, that's where we get our baseline. I don't think we have done really our own testing, our own assessing in the other areas of grant-making focus. In the bioscience area, we belong to a trade association called the Health Research Alliance. And these are all the private funders of medical research, all the way from like Howard Hughes Medical Institute to American Cancer Society to the Mount Sinai Foundations of the world. So it's maybe 100 organizations. They meet twice a year. We do a lot of benchmarking with them. We're a little different because our focus is so heavily on Case Western Reserve and its School of Medicine that you know, there's not a competitive aspect exactly, but we want to know benchmarking-wise where we are with Case and where our investments are needed. So we look at other grant makers and what they're doing in other cities.
Mitch, what's your process for keeping your board educated on all the subject matter expertise that they need to make grants across
Right,
these 4
right. Great question. So at every board meeting, we try to have an educational speaker, an educational session, and it's almost always aligned with some place we want to go strategically. So if it's early childhood obesity prevention, we will have, I'm blanking out on the name, who's got his grandchildren in Cleveland, so he's great to get here. A content expert to come in and talk about, well, give us the baseline, give us interventions that are evidence-based, and that's kind of how we do it. We probably don't do enough. We often do also at those advisory committee meetings. So at the Academic Medicine Advisory Committee meeting, we had a presentation on nanomedicine. And at the Jewish Advisory Committee meeting, we had a presentation on Alzheimer's. So areas where we are about to make a leap, potentially make a leap, considering making a leap of significant dollars, we do very focused educational sessions. Yeah. Wow, I think it's both. And I'll tell you, with the addition of Dan Cohn, it's happening a lot more internally than it used to. I mean, we used to steal great ideas, from other cities, right? You'd go to a trade association meeting and you'd say, yeah, we got that problem in Cleveland too, and that sounds like you're doing something really effective with that. We pick a field, right? So let's say it's early childhood, and we educate ourselves, staff, as to evidence-based interventions. So the Nurse-Family Partnership is a great example, and I know some of you know about this, but Nurse-Family Partnership, home visiting program for new moms, first-time moms only, prenatally to age 2, like a magic bullet. 30 years of evidence that shows not only healthier birth outcomes, but incredibly powerful lifelong benefits for mom and baby. So like 60% less likely to ever be involved in the criminal justice system or juvenile justice system for babies who went through the program versus a control group. And this has been tested in African American communities and Hispanic communities, and the original study was in Elmira, New York. Same thing with moms. I mean, just one statistic, 60% less likely, 60% moms more likely to go back to school or work after the baby comes if you've been through Nurse-Family Partnership, if you've received that kind of support. There's some magic that goes on between nurse and mom that, is hard to explain, but it's there. So anyway, we brought this program to Metro. We committed $1.2 million to do that. That was because we read about the program. We kind of knew about it, but it was kind of bubbling up again after many years. And make a long story short on this, we committed a lot of money. Sisters of Charity committed some money, Gunn Foundation and the Myers Foundation. It's like $2 million to launch it over the first 3 years of the program. And we went to Detroit to go to school on their recently launched Nurse-Family Partnership program. And we said, how do you support this ongoingly? And they said, we get McVie money from the federal government. We said, what? McVie money? Tell us about McVie. So you guys know about McVie. And Martha Wright? No? So this is the Maternal Infant Early Home Visiting Program. Cleveland has never gotten a penny of this money. With our African American infant mortality rate, the highest in the country, we've never gotten Nurse-Family Partnership money. This money is fairly wired to Nurse-Family Partnership because it is such an evidence-based program. So because we never had Nurse-Family Partnership in Cleveland before, we never had access to this money. It also goes to a program called Healthy Families America. Make a long story short, we ended up getting $560,000 from the feds the first year and $600,000 in this new year because we're doing great with the program. Metro's doing great with the program. They already enrolled 100 moms, and we thought we would take a year to do that. It only took 6 months. So that's an example of how we go about our strategic work. Thank you for the opportunity to address you, and really good luck. And my door is open. you know, some of our best grants have been really small grants. And I'd have to go through to give you examples. But you know, sometimes the size of the grant it's not what drives the impact. Especially if you can get farther away from healthcare and get upstream, like you all understand you kind of need to do. It's doable, you know. It's very doable. Very much so. 1 + 1 makes 3. 100%, and Randy can speak to this better than me, but you know, in other cities, grant makers don't partner as much as Cleveland. I mean, Cleveland is unbelievable, not just like the Fund for Our Economic Future that Randy's been so involved with, but I don't want to call it collusion, but we really work together. I mean, the staff of the St. Luke's Foundation and my staff are constantly in touch because we get a lot of the same grant proposals, but we want to get their wisdom on these things. So we're not in lockstep, but we really do partner all the time. Totally. Absolutely, right. Yeah, I mean, the O'Neill Foundation right now is launching a 2-gen approach. You know, you can't just deal with the child, you have to deal with the parent and make sure the parent is successful so that child can be successful. And we're all benefiting from their wisdom, from them bringing us in. And again, they're not the biggest foundation in town, but they've got this very solid strategy, and they're sharing it with everybody, and it's benefiting all of us. Thank you. Dan knows got to get a hold of me as well as Randy.